tuned in once again to a brand new episode of iMed here on Channel I. Hope you're all doing well and hope you've been having a fantastic week. Now, as always, we at iMed hope to bring to you insight into all your medical and health-related concerns, while we also try to bring awareness into any other conditions or disorders that may need that sort of awareness. Now, today we are coming to you once again from the National Hospital of Sri Lanka, and we are very honored to have with us here today Dr. Monica De Silva, a consultant rheumatologist of the National Hospital of Sri Lanka. A very good evening to you, doctor. Thank you so much for taking the time to be here with us today.
Good evening.
And as always, today's episode will be discussing the topic of rheumatoid arthritis. Now, if you already knew, it is a chronic inflammatory disorder that can affect more than just your joints, like the previous topic that we discussed, which was osteoarthritis. Now, there's a lot of information that we will be highlighting in today's conversation, and also once again we will be exploring the treatment options. And to begin with, doctor, if you could just tell us what exactly is rheumatoid arthritis?
Rheumatoid arthritis is a type of inflammatory arthritis, and it's autoimmune mediated. That's why the rheumatoid factor is an autoantibody. And in rheumatoid arthritis, typically small joints of hands and feet are affected, but most of the other joints can be affected. And there is synovial involvement with inflammation, and in addition to this joint involvement, there can be other organ involvement as well, like they can have lung disease with lung involvement and eye inflammation, and like dryness of eyes, and also they can have nodules under the skin called subcutaneous nodules. So in addition, they can have like systemic symptoms like lack of energy and malaise, fatigue like symptoms.
Okay, doctor. So now that we discussed what is rheumatoid arthritis, there is also the fact that it is an autoimmune disorder. If you could tell us exactly what this means and what exactly happens in this situation.
So there are a lot of autoimmune disorders. In autoimmune diseases, the body produces antibodies against self tissues. So these antibodies are usually formed against the foreign antigens like viruses or bacteria to protect the body from these foreign antigens. But in autoimmune diseases, antibodies are formed against self antigens or self tissues. So rheumatoid arthritis is also a type of autoimmune disease where autoantibodies are seen.
So discussing about the fact that it's an autoimmune disorder, doctor, could you also maybe take us through the correlation or the similarities, or whether having rheumatoid arthritis could lead to osteoporosis, or if it has any correlation to what we discussed in our previous topic, osteoarthritis?
Rheumatoid arthritis, there is association with osteoporosis as well, because they are patients with rheumatoid arthritis, they are more prone to have osteoporosis and like anemia, and also they have high cardiovascular risk and increased risk of heart diseases like heart attacks. They have increased risk of that heart diseases as well.
Okay, doctor. So now talking about the correlation, the similarities, or whether it can lead to osteoporosis. When we talk about rheumatoid arthritis, once again, what are the demographics like? Who is at risk, and what are the risk factors related to rheumatoid arthritis?
Rheumatoid arthritis is also commoner in women, and usually begins around 30 to 50 years of age. But at any age, even in children or in elderly also, they can be affected with rheumatoid arthritis.
So once again, doctor, you mentioned that gender plays a role in rheumatoid arthritis as well. Could you elaborate as to what exactly happens that leaves women at more risk than men?
That of course may be because it's like genetically susceptible individuals get rheumatoid arthritis. That may be on exposure to unknown antigens, maybe infection or particularly infections or smoking. So these can precipitate in a genetically susceptible individual rheumatoid arthritis. Yeah.
So, Doctor, now that we discussed how gender plays a role and how women are at more risk, you also mentioned anemia playing a role, portraying itself as a risk factor. How exactly does this work? Does nutrition or diet have anything to do with it?
Actually, when they have rheumatoid arthritis, as in any chronic disease, there can be anemia. So then in blood cells are produced in bone marrow, there can be reduced cell synthesis in the bone marrow due to the disease activity. Sometimes really it may be due to medications that use that may, if NSAIDs are used, these can cause GI blood loss. But if there's severe anemia, then we'll have to see whether there's any other cause for blood loss. But it's usually due to it's called anemia of chronic disease. It's due to the disease activity.
Okay.
When disease is controlled, so the anemia also can get corrected.
Okay, doctor. So now we discussed on how common it is and the role that gender plays. Now, as we all know, as we just were informed, rheumatoid arthritis affects the organ systems of the body. If you could highlight very concisely, very in detail, as to what organ systems are affected for one suffering from rheumatoid arthritis.
Particularly lungs. So sometimes there is a belief or new thought whether the rheumatoid arthritis begins in the lungs, because some respiratory infections and smoking precipitates the disease. So if they have like cough or like short of breath, so that can be due to lung involvement of rheumatoid arthritis. So always whenever the patient comes with rheumatoid arthritis, we inquire about these respiratory symptoms, and we auscultate, we listen to the lungs to see whether there are any evidence of lung disease. And sometimes rarely, so they can initially begin present with lung symptoms, chest symptoms, and later to have joint involvement later. And as other things, so dryness of eyes and sometimes dryness of mouth. That's also called Sjogren's syndrome. So they can have secondary Sjogren's syndrome. They can have dry eyes and dry mouth. But if there is severe dry eyes, so they can get corneal ulcers and sometimes even can go blind if not attended that one eye involvement. Sometimes they can have red eyes, like inflammation of the eyes, the outer layers, particularly outer layers of the eye, like it's called episcleritis. And they also can have nodules under the skin called subcutaneous, usually seen over the forearms mainly. So they can have skin nodules. These are like symptomless, like painless nodules. These also do not cause much harm. And usually the rheumatoid arthritis does not involve kidneys. But another important thing is cardiovascular risk. Particularly if the inflammation is high, their risk of cardiovascular risk is high. So they are more prone to get ischemic heart disease or heart attacks. So control of inflammation is important in reducing cardiovascular risk as well, because it's fair percentage of patients with rheumatoid arthritis die of cardiovascular disease.
So, doctor, now that we discussed the fact that it attacks the organ systems in our body, once again, when we move back to the topic of rheumatoid arthritis, it affects our joints, but obviously just more than our joints. If you could just tell us, what are the joints that are mainly affected, and what are the stages of pain like? Does this also progress in stages like osteoarthritis?
Mainly, typically small joints of hands and feet are affected. But as I told, any other joint of the body can get involved. Typically, symmetrically, both sides are involved. But at the beginning, so there may be only one or two joints are affected. Then then the diagnosis also sometimes can be delayed due to this one or joint affected, and patient may not notice typical symptoms. And typical symptoms of rheumatoid arthritis are pain. So they get pain. So even sometimes it's constant pain, unlike with osteoarthritis, they get pain after activities. They can these rheumatoid patients also can get pain after activity, but they usually they have constant pain as well if untreated, and swelling of the joints. So always you have to, the patient complains of swelling, and we have to see whether there is swelling, and then stiffness. That's an important physical sign, symptoms. That's important symptoms, because in rheumatoid arthritis, they have stiffness in the morning when they get up from the bed. So they have stiffness. It typically prolonged morning stiff. This is called morning stiffness. This is almost always more than half an hour. Sometimes, if it is severe at the beginning, the stiffness may last throughout the day. And then examination, we have to look for swelling and pain. But stages means, so in rheumatoid arthritis, the most important thing is, so this also causes joint damage, but most impact on joint is within first 2 years of life, first 2 years of disease, sorry. Within first 2 years only they get the most of the damage. So that's why the early treatment is needed. So once joints are damaged, so we can't protect the joint, we can't make these joints through the normal joints. So so initially it's inflammation, and this inflammation causes destruction of the joint, and once destructed we can't revert back. So with destructed joints, there can be secondary osteoarthritis as well.
So doctor, you just spoke about the typical presentation of rheumatoid arthritis, the signs and symptoms that one is most likely to see and feel. Now, talking about that, are there any atypical forms of presentation, and how do these present themselves?
Sometimes if they were given steroids at the beginning by some form of steroids, so they may not have typical morning stiffness, but they may have swelling. The pain also may be less. And if it is only 1 or 2 joints are there at the beginning, that's also atypical. So initially, so it can be missed. And in the meantime, there are other causes for even polyarthritis, for other causes as well. So like psoriatic arthritis, lupus, they also can present with polyarthritis, just like rheumatoid arthritis. So it's important to make the diagnosis of rheumatoid arthritis, particularly by a rheumatologist.
So talking about the atypical forms of presentation, doctor, can we also discuss the extra-articular manifestations that will occur in somebody who is facing or undergoing the disorder of rheumatoid arthritis?
So extra-articular features means the involvements other than joints. So as I told, there can be eye involvement with dry eyes and result in corneal ulcers. There can be lung involvement. It's also called fibrosing alveolitis. Sometimes they also can have bronchiectasis, other lung involvement as well. And they can have nodules. And then also they are more prone to have carpal tunnel syndrome. Sometimes they can have like trigger fingers. Is also they can have. And in those days, so there's atlantoaxial joint subluxation or that neck involvement was there because they with delayed treatment or poorly controlled treatment. Nowadays we don't see much of these complications, but lung involvement we see.
Okay, doctor. So doctor, now before we move on to diagnosis and treatment, is there any way, because you mentioned that there is a specific gender who is at more risk and things like anemia coming into play, are there any forms of prevention that one can take on at an early age? Also the fact that you said that it might be hereditary. What are the forms of prevention that we can take in order to not get the disease?
Actually, there are no such preventive measures as such, but avoidance of smoking, and again the obesity also can be seems to be a precipitating factor. So avoidance of that weight reduction, and particularly if there's family history, these measures, only these measures are nothing. They are particularly to prevent getting the disease.
Okay, so prevention seems to be posing itself as a bit of a complicated situation, doctor. Now moving on to the diagnosis, what are the diagnostic criteria that we look into, and how important is it for one to immediately go in and seek treatment as soon as they are seeing the symptoms?
Actually, these are there are no diagnostic criteria as such. These are called classification criteria. These are there to include the patients to studies, research studies. But whenever if the patient is having small joint pain and swelling with morning stiffness, particularly if it lasts about 6 weeks or 6 weeks or more, and with ESR, the inflammatory markers are high, and rheumatoid factor may be positive. So in this patient, we have to make the early diagnosis. Diagnosis is important, particularly if the pain, swelling, and stiffness, prolonged morning stiffness is there. Sometimes, even if there's no stiffness, if there's swelling of the joint, it's necessary to attend the rheumatology clinic to be seen by a rheumatologist to see whether it's rheumatoid arthritis.
Okay, doctor, we just discussed the classification criteria on how to diagnose somebody with rheumatoid arthritis. Now, before we move on to treatment, doctor, let me once again ask a question that I'm sure a lot of our viewers also have the same question. The fact whether is it curable, and even if you are able to diagnose it at an early stage, and if you do get treatment, is it curable completely?
To answer that question, certain percentage, so they can have remission, long-term remission, but the aim of our treatment is to prevent joint damage and to enable pain-free life. So for that purpose, if we treat early, that's I told, the most of the joint damage is within first 2 years. So if the patient come to us early, so early treatment can prevent the joint damage, and then it's possible to live with minimum pain.
So talking about the fact that whether it is curable, doctor, also I would like to ask what happens with the extra health complications that will occur, like we discussed with osteoarthritis. For somebody suffering from rheumatoid arthritis, what health complications will they be facing long term and short term?
Short term, they can have pain. So because of pain, if the pain is not controlled adequately with treatment, so they also can have like sleep disorders, depression, so other psychosocial issues, and then other involvement other than joints, so due to other like lung involvement, there can also be complications with these. And long term, so they are more prone to get osteoporosis, and the other thing is joint damage and increased cardiovascular risk of having ischemic heart disease, and so these complications are there on long term.
Okay, doctor. So now the fact that you mentioned that it could progress on to become osteoporosis, somebody getting early treatment and being diagnosed early on during the early stages, is it possible to not reach that stage, or is it going to happen anyway, the progression?
Actually, osteoporosis is not really as a complication of this disease. It's not so osteoporosis is there with rheumatoid arthritis. So we can't with treatment. So if there is we have to find whether there is osteoporosis, and if the fracture risk is high, we have to treat osteoporosis. Otherwise, though risk is high, not everybody is getting osteoporosis.
So once again, it's a bit of a complicated issue when it comes to diagnosis and treatment also, and also stopping the progression of the symptoms while we try to alleviate the pain. So thank you so much to everyone who tuned in today. I hope you educated yourself a lot on the topic of rheumatoid arthritis, and we were very honored to have with us here today Dr. Monica De Silva, consultant rheumatologist of the National Hospital of Sri Lanka. Thank you so much for being here with us today, doctor. And for those of you who tuned in today, we would like to invite you to join us again next time on our next episode, where we will be discussing the treatment options that are available for rheumatoid arthritis. So until then, take care and see you again.